of introduction of pediatric palliative care, oncology, and beyond. What does a palliative care program look like? Idea of general palliative care. So I am Lailatul Firdaus, Senior Staff Nurse from Department of Palliative Medicine, BSMMU, Dhaka, Bangladesh. Just a few reminder for today's session. Please do not hesitate to ask any question in the chat. We have faculty members who are monitoring the chat and will respond to your questions. We want to make sure you understand everything. If you Zoom etiquette points, please make sure that you are on mute unless speaking. Use chat box for any questions and discussions. If your audio is poor, then we suggest switching off your video. Now, I would like to introduce our first speaker for the session, who is Dr. Megan Doherty, Pediatric Palliative and Director, South Asia, Towards Cancer, and Program Director of Palliative Care, Children's Hospital of Eastern Ontario, Ottawa. She is working hard to establishing pediatric palliative care in South Asia. Over to you, Dr. Megan. You have 15 minutes. Thank you.
Thank you very much, Laila. A very warm welcome to all our participants today. We have a few new participants who are joining, so I especially welcome them, which is Dr. Kanis and some nurses from Dhaka Medical College, Vaskar and Ruhul. So really nice to see you today, and thank you for joining. So just a reminder, if you join all of the sessions, there's 6 in total, then you'll get the certificate at the end. And this is a very introductory course. And after these 6 weeks, we hope you'll have a good understanding of the basics of palliative care for children. And then we do offer more detailed and more specific training and clinical training as well in Hyderabad. So we'll tell you about the other things you can do after you finish this course. So this is, we shared a video for you to watch to prepare for today, which goes over a lot about pediatric palliative care very nicely. And we did start to talk about it last week. So today we'll just give a bit more of a summary so we all have a good understanding of what is palliative care for children. And then we'll talk about it in the context of patients that we care for. We have an example of a patient today. And then every week we're going to go through different topics that are very important: communication, pain management, symptom management, and how we care for children at the end of their life. And we talked about this last week, the importance of combining palliative care with potentially disease-modifying treatments. So we don't just think of palliative care as end-of-life care, which happens right when the child is in the last weeks of life, but we think about how we can do palliative care and we can integrate it into the care we provide for children with serious illnesses and cancer from the time when they're diagnosed, because we know they have a lot of symptoms, their families need support and communication from the time of diagnosis when the child becomes ill. And so this is kind of one drawing showing that idea, where the light blue is disease modifying treatments and the dark blue is palliative care. And you can see that these blend together in the middle, and that maybe over time the palliative care needs increase. And we also do care after a child passes away or dies. We call that bereavement care. So this is just one idea of how palliative care integrates with other parts of medical care. A few myths that we talked about in the video about palliative care. And one thing we emphasize is that it's not very helpful to say there's nothing more that can be done. That gives parents the feeling that you're giving up on their child, that you're not going to keep giving care. It makes us as doctors and nurses feel that we may have failed. We failed to succeed in our treatment. And we want to just emphasize that there's always something more that can be done. We can always look at the child, help them with their symptoms, support the family, and stay with them. And some other myths about palliative care that we really want you to understand and change your ideas about, and also change the ideas of the people you work with, is that palliative care, it's not just available when we have no more curative treatment. We've talked about this, it should start early. We also, sometimes people think that palliative care will bring a child's death sooner, And we know that's not true. In fact, it seems that for children who take palliative care, they seem to live a little bit longer. And it's probably because the treatment matches more the child's condition. And so they don't get too much treatment that's toxic or harmful. Sometimes people think, oh, palliative care can only be given at home or can only be given in the hospital. But we know that palliative care can be provided in any setting, can be in the hospital, can be in another type of health facility, can be in the child's home, can be in a specialized facility called a hospice. So all of these are places where we can give palliative care once we set up our teams and our services. And I think I showed you this slide last week and it's in the video, but we like to emphasize this, how when we look at all the children in the world, and that's what's shown in this circle here, if we look at the total of all the children who need end-of-life palliative care in 1 year, these are the conditions that they die from. And the most common is the congenital anomalies and the neonatal conditions. So that's where there's a bigger need for palliative care overall. And in fact, in total, cancer is only 6% of the children who need end-of-life palliative care. But we know that often those are the children we start to find in our programs first. But there are many other conditions that we talked about last week where palliative care is very helpful. When we think about how we do palliative care, so now we know who we need to do it for, when we should do it, but how do we actually help patients? What do we do for them? This is how I think about the work that I do. I think about there being a need for physical care. So do they have pain or other symptoms? And we'll teach you how to manage those. Do they have emotional needs that we can help with through counseling, social work, psychology, and other supports? And we say emotional, not just psychological, because sometimes it's just talking about how they feel as children and how they feel with their illness. Do they have social needs? So that means thinking about the child and also the rest of the family, the school children, the community, their friends, whoever interacts and lives with that child and shares their life. They need support from us sometimes. And then their spiritual needs as well. And we talk about bringing in religious leaders, spiritual supporters. In some places, those are called chaplains. They're like people who are trained to give spiritual support. And some hospitals have them. And if you don't have those, then you find out who is a priest or someone from their that family's religious group who can support the family, perhaps. And then lastly, we think about trajectory. So trajectory means what is the way that the child's illness is going to go. And you remember last week I showed you all those curves of how does the child's illness change over time. So, is it going up and down? Is it slowly going down? And we want to plan for the future and make some plans so that when things change, it's not an emergency and a crisis, and we have a plan already. And we emphasize that palliative care is not just for the specialists to do. It's that we all share a responsibility for whatever patients we see to give them what we call a palliative care approach. So that means that all of us in healthcare, we can do a palliative care approach where we give them some support in all of these areas. And if they have very complicated symptoms or complicated and specialist level needs, then if we have access to a specialist pediatric palliative care team, we can refer them to that kind of a team. But the pyramid is larger at the bottom here for the palliative care approach, because that's where the majority of palliative care is delivered. More patients are in that group where they just get general palliative care or palliative care approach. And here we see a good reminder about teamwork. And this is how we think about our palliative care team. This slide comes from our team in the Coral slum in Dhaka, who provides palliative care there. And this is how the team works. We have the patient and the family at the center. And then you can see we have all of these other people around the team who are supporting: pediatric physician, nurses, palliative care assistants who are community health workers, community volunteers, we have a physiotherapist, and we have a coordinator. And these people all work together to build the team around the patient and family at the center. And in the video, Dr. Natasha talks about some of the other ways that we have skills and we develop skills to do palliative care. And we talk about these 4 things: identify, assess, plan, and manage. And what we mean by that is identify the patients early who could benefit from palliative care, then assess them. So think about their illness, what information do they need, what kind of communication, breaking bad news, perhaps. Assess their symptoms, their psychosocial and spiritual needs, their quality of life, their values and wishes and preferences for how they want their child to get care. Then once you know what they need from the assessment, then we plan it in terms of something we call advanced care planning, which is making plans for how the child will be cared for in the future. And some other types of plans are listed here. And then we would manage their symptoms and their needs as well. I want to highlight a slide that Dr. Natasha had that I think is really important and helps us in our care. So one thing we know is some studies have been done about what do parents need when their child is seriously ill. And this is what the parents said when they were interviewed by researchers. They need recognition from clinicians that they know their child best. So we have to respect them and listen to them. And if they say, I want my child to be at home, that's where my child will be best cared for, then we have to listen and work with them on that. They need to feel that they are good parents. So it's helpful if we say, you're doing a really good job, you're being a really good parent, this is how many loving parents would care for their child. These phrases will help the family feel more calm that they're doing the right thing. Parents specifically say they need clear and honest information. And I think this is one area where it's very challenging to always give the information, but we need to work on being better at that. They want the information, but they also want us to communicate it in a caring and sensitive way so that they feel that they're not, it's not hurtful the way it's delivered. And so that's when we sit down and we have a good conversation with them. And we'll talk about that next week, how we do that well. They want to be able to trust the clinicians, trust their nurses and doctors. And if their child's going to die, they feel that we should prepare them for that. We should tell them we think that's happening, and we should help them as healthcare providers to make plans for how they can care for their child at that time. And on the other side of this equation, we look at what do the children need. So we've talked about the families and now the children. These are the things that are most important for children when they are in such situations. They tell parents, they want to know that they're own, they want to feel loved, they want to feel that they're looked after. So this is very important. And when parents say, what can I do? What can I do for my child? Then telling them what you can do is stay with her, look after her, be with her, hold her. This is what's really important for children at the end of their life. They need that loving and attention and nurturing attention. And then we also know that children need simple, honest, and age-appropriate information. So we will talk about it more in detail, but we do need to give children some information about what's happening with their condition. And lastly, children need to play. Play is therapeutic and helpful for children, especially when they're sick. This helps them cope with their illness. It gives them a place where they can experience normal childhood. And we find it to be very, very supportive for children who are ill. When we think about communication, and like I said, we'll have much more discussion on this next week, one of the most important phrases that we can use that is very helpful is this phrase, I wish, worry, wonder. It's called the I wish, worry, wonder framework. So here's an example. You might say, I wish that things were different, but I am worried that your child is very sick and the medicines that we have are not going to make him better. I wonder if we should plan for a situation where he continues to get sicker or things do not improve. So this is a very gentle way of starting to have a conversation and say how you as a healthcare provider feel about the patient and what you're suggesting to the parents that they do next. And we'll, again, give you more examples next week. But I want you to think about this phrase and think about how you would translate it into the language that you speak to most of your patients in. And many times you may hear from your colleagues or other doctors and nurses that if we give information to the patients about truly what's happening or to the parents, then they'll give up hope. But really what we know is that from the studies, if we communicate honest information about prognosis, that doesn't take away hope. So here is a study that was done looking at how much hope the patients feel before they get the diagnosis and after. And there's like a questionnaire that you can ask patients to fill out, which has a number of questions, and it gives a score for how much hope they feel. It's called the HERTH. And so they gave that questionnaire to a lot of patients before they were given their diagnosis. This was adult patients. And then again, after they had the diagnosis. And when they were told the diagnosis, they were also told the prognosis. So they were told like a number, like you have a 40% chance of being cured. You have a 40% chance of surviving this condition. So they actually gave them very honest and clear information. And you can see that these two scores were the same, basically. So that doesn't change how much hope people feel. So in summary, I want to emphasize again the point that I said last week. We cannot add days to their life, but we can add life to their remaining days. And that's our sort of guiding philosophy. We talked again just about what is palliative care for children and who qualifies, the different types of conditions. And then today I focused a bit more on how we can help them. We talked a little bit about pain and symptom management, how the care can be in the hospital or at home or other places where children stay, and different types of emotional and social and spiritual supports that we can provide. So I will wrap up there. And if you haven't watched the video, I would very much encourage you to please watch the video so that we all, so you all get all the information that Dr. Natasha shared in that video, which is very valuable.
Thank you, Dr. Megan, for your nice presentation. Does anyone need clarification of any points? Now we have a few minutes for questions and comments from everyone. If you would raise your hand or unmute and ask your question, or you can type your question in the chat and I will read it out.
I have a question for Megan. Sometimes I find it difficult to introduce my service or the fact that I'm working in a palliative care role. And so how do you introduce yourself to parents the first time when you're going to be there knowing that the child is very sick and you're going to be helping them with palliative care symptoms?
Thanks, Kamara. That's a good question. So the question is, how do we introduce palliative care, especially if you have a specialized palliative care team that's going to meet the patient? So I think before the palliative care team comes, if you're the doctor or the nurse looking after the patient, then you should warn them that you're going to introduce them to another team, another doctor, another nurse who's going to come, and that's called palliative care. And that team is going to help their child with the symptoms and other issues that they're having. So giving them a little warning is important. And then when I come as the palliative care doctor, I explain my team and how we are going to help the patient. So I usually say that, I'm a specialized team that works with children and families who have serious illnesses. And I might explain what I mean by serious illness, meaning an illness that is quite significant, is going to last probably for a long time. Maybe the whole of the child's life, there will be medical issues that the child is having. And I explain that sort of at the level of what the parents understand in terms of just what their level of understanding of the illness is. And then I explain what my role, our team's role will be, supporting the child with pain or other symptoms that they're having and helping the whole family manage having this illness. And I usually explain that, when your child is sick, it's not just the child who has the suffering from the illness. We know that it affects the brothers and sisters in the family. It affects the mother and father or the parents and other members of the family. And so we know that for the child to have the best quality of life, we have to support the whole family and help you all to care for him or her. So I explain that and kind of have a discussion from there. And usually that parents see that that's a way that it seems like it's a, it's a positive thing, that they're getting more support and their child's, suffering and quality of life will be improved.
Thank you, Megan. One of our participants, Bituran, he asked how much the education level of parents accept the sad news or the bad news. I request Megan.
So that's a really good question. I'm glad you asked that, Dr. Vidaran. And I know that's a question that many of us have. How do we manage? Because some of our patients have very limited, their parents have very limited education or very limited understanding of like the healthcare system and health and how it works. So we do have to adapt our communication to their level of education. So definitely one thing that's very helpful we find is when we come and we're going to give palliative care and we're going to communicate with the parents and give clear information about what's going on with the child. One of the first questions I ask is to the parents, and I say, can you tell me what is your understanding of your child's condition and what's happening right now with him or her? So then first get them to tell you in their own words what they know. This is, if you just do one thing, this is a very important thing you can do every time you meet a family and you need to communicate with them about the child's condition. This will help you know how much they understand and also the level of understanding. Like if they just say he has a sickness, or if he has a tumor, and then you can say, well, what does it mean to have a tumor? And then they may say, I don't know. Maybe it's a cancer. It's a thing the doctor said it's cancer. And then maybe you explain a little bit more so they understand what it is. But we do have a responsibility for any level of education of our patient to give them information about what is likely ahead for their child. So another question we often ask is, how much information about what is likely to happen with your child, about what's going to come in the future for their health, would you like? And the vast majority of families will say, I would like to know most or all of what's going to happen to my child, right? Or if they say, I don't want to know anything, then you say, is there somebody I can tell in the family? Is there someone who I could share this information with so we can work together to be prepared? So maybe it's just that you're not talking to the right family member. Maybe the father wants to hear aside from the mother, or not having the mother be there. That's sometimes quite common, but it's important to ask the mother also if she wants to know the information, right? Or, whatever the parent situation is, making sure both parents get the information they need.
Thank you, Megan. So there is another comments in the chat that Dr. Jannat asked that how meat affects the parents and what is the role of the palliative care in this situation?
Can you explain the question a tiny bit more, Janet? What are you thinking there?
Thank you, Megan, for a nice presentation. Actually, I want to know the meat in different society or in a very cultural background. Sometimes it affects the parents or even children. Actually, how? When they are in disease condition, number one. Number two, in this situation or in this respect, what will be the role of palliative care? Just to alleviate them from this situation or to make them understand these are myths, these are not the real fact, or something like this. Actually, I don't know. Thank you.
So like myths, like the cause of the child's illness, like they might think it's like from evil spirits, or they may have an explanation that's sort of non-medical for why the child has become sick. That kind of a myth is common. So we often see that, and I'm sure Dr. Bat, especially you see this pretty frequently for patients with cancer and other serious illnesses, that when the child is very sick, the parents say, well, what did I do to cause this? Is it bad food? Is it bad water? Is it evil spirits? Is it karma? Is it, we haven't prayed enough? There are many, many things they think might cause it. And I think it's important for us to listen and understand what their thinking is. So saying, understanding from them, well, what do you think about why this happened? So that they share a little bit, and then you can talk about what you know about why the illness might have come. So for the example of cancer, they might say, well, is it because the water's not good or the food is not good, there's pollution, and you can say, no, we don't think so. For children with cancer, we don't see any specific cause for that. It's nothing that you did as a parent, or there's no reason why this happened to your child as opposed to another child. And especially, sometimes for babies, if they're born with problems, then the family will blame the mother. The mother didn't take proper care in the pregnancy, or she ate something, or it's something to do with the mother, how she's caring for the child. And again, we can tell them, explain to the family that, no, we see this coming, and it comes it doesn't have anything to do with what the mother did in the pregnancy. So that the mother can feel not that relieving from the guilt that she might have. So I think we have a responsibility to share what we know, but maybe Camara or somebody else wants to say a little bit more what their perspective is about that.
Thank you, Megan. I would like to add something with you. I'm totally agree with you that whatever we know, we should share with them. Beside that, as a palliative care team, we should, increase awareness among the neighbors within community, so that they also could understand. Sometimes neighbors also blame the mothers, or parents for that, particular disease this child is, suffering. In that case, if we could creating awareness among the community, that is also, help for the this kind of families. So this is a little thing from my experience I wanted to add. That's it. Thank you.
Thank you. That's a really good point. I think especially that's very important. And, your work with the children in the Coral slum probably really made that quite clear, because, you have to talk to the other families in the courtyard and the area around, so that they don't discriminate against that family and say, oh, that mother didn't do things right.
Hi, Megan.
Hi, Dr. Bat, go ahead.
Yeah, so thanks. Nice presentation. I just wanted to add to what you said. So we do come across the situation where, a lot of mothers are blamed, and then the fathers actually abandon and, the family, and, it's just the child and the mother. Right? So what we do is, apart from like how you said that we initially ask them what they know about the condition, what do they feel about how this disease was there, how the child acquired the disease, and try to clear out most of the myths probably in the first couple of sessions that we have as soon as the diagnosis is done. And most of the time it works, but you have these one-odd families where it is absolutely difficult, and then we have to intervene, and we request then other people from the team, or our social workers, or say even our palliative care team also to intervene at that time.
Thank you. That's a good suggestion, is, baseline everybody, you do this, and then if you need the extra support for the really challenging situations, you can do that. So what about, can we hear from somebody in Sri Lanka? Maybe Dr. I know Dr. Vitharan is in Sri Lanka. Is it any different in your situation? How do you manage with the myths that the patients have or the families have?
Yeah, thank you. Usually we are also having the same problem, like explaining to the family and their educational levels and myths and misconceptions. Sometimes some people are reluctant to understand the situation and follow up the managements and treatments. So during that time, we try our maximum to explain them the situation, and the same thing like natives or relatives will tell to go to the different kinds of hospitals and kind of doctor shoppings and changing the areas, maybe thinking like it may be a sin or something, and there are some problems as well. So it's kind of a challenge, especially in the condition where low educational levels of the family. So that's why I asked the question as well.
Thank you. Thank you all for your questions. We have to now move on to our case presentation. Please continue to ask questions in the chat, and we will answer them in the chat as best as we can. If there is time later, we will try to answer them after the case as well. Now, I would like to introduce our case presenter, Dr. Janna Tara, Assistant Professor, Pediatric Hematologist and Oncologist from Dhaka Medical College Hospital, Bangladesh. She is doing excellent work in providing pediatric palliative care in Dhaka Medical College Hospital, Bangladesh. Over to you, Dr. Jannat. You have 10 minutes. Thank you.
Thank you, Lara. Sorry, I need to do a video off because some internet disturbance is still going on. Respected lovely participants, honorable faculty, respected rapporteur, welcome you all to this nice novel session. I'm Dr. Jannat from Dhaka Medical College, Bangladesh. Today, I'm sharing a case presentation with you. Actually, similar case sometimes we can see in our country, even in South Asia also. It is very much touchy and stressful and very much moved. So which in this condition, actually we need to alleviate this or think empathetically. Before starting the case, I'd like to share 2 points regarding this case. One thing, what are the source of this child or family sufferings? Number 1 question. And number 2, how can palliative care help this child and family? Next, please. Parents detail. 9 years old young boy with osteosarcoma with left lung metastasis. Osteosarcoma is a very common bone cancer in children, especially in adolescents. Common means not that it is very common child cancer, but as a bone cancer, this is a common varieties. And it is generally occur in adolescent period, suppose 8 to 12, 13, 14, even 20. In this period, it is very much common. And it is very much painful. And the lung is the common site for metastasis in osteosarcoma case. And probably in our setting, generally this kind of child has come after 7 to 8 months, even after 12 months also, when extensive or in stage 4 cancer. In this way, sometimes they may come. So this child having osteosarcoma with left lung metastasis was initially treated by medical oncology team at a private cancer center with chemotherapy and amputation discussed but not yet completed. Here also I want to add one thing, that the mainstay of management in case of osteosarcoma is surgery. But most of the time they have come with the extensive or beyond the surgery. In that case, initially we have to do the chemotherapy and make it smaller, then do the surgery, that is limb sparing. Basically osteosarcoma actually occur in limb, upper limb or lower limb, especially in lower limb. So we want to spare the limb, but sometimes when it is extensive, in that times we have to go for amputation of the that limb in a thought that sometimes losing the limb but saving the life. in that thought, actually we are doing this. So in that case, chemotherapy, that is before surgery, chemotherapy is done, but amputation not yet done, or discussion is going on. But simultaneously removal of lung metastasis, because lung mets is very much common in that case, which could be removed, and after removal, curative or the survival also increase in these cases. Sometimes it also better palliative care also we can give in this case if you can remove the lung mets, because it is a very common area. That is done in this child 2 weeks ago. Has now developed spinal cord compression due to metastasis in the thoracolumbar spine. That's very stressful. Next slide, please. Generally in osteosarcoma, patient has come severe excruciating pain and systemic manifestation, fever, anorexia, weight loss. With this symptom generally come if having metastasis in anywhere, having this kind of symptom will be added. So in this case, the child having pain in the leg, leading to child to be extremely agitated and restless. Severe pain actually occur in that period. Also complain of pain on the right side of the neck and upper chest. And along with this breathlessness and complain of cough, shortness of breath, grunting and moaning, probably due to because surgery is done, and again having lung mets also, though it is removed. And along with this, poor sleep due to uncontrolled pain. So excruciating pain, one of the this kind of palliative malignancy where pain is severe. This is one of the thing is the osteosarcoma, severe pain actually. And loss of mobility and bed bound due to spinal cord compression requires urinary catheter. Next slide. And with chemotherapy or planning for surgery or ongoing surgical procedure, these are the supportive or palliative medication also going on. That is per oral morphine 5 milligram every 4 hours, and additional dose explained by breathlessness. And per oral dexamethasone 4 milligram daily for 5 days, and for laxative purpose dulcolax per oral 10 milligram QoS. Next slide. Beginning psychological history. Apart from this child, elder son has developmental delay for which parents were distressed as well. This is a very distressful condition for the family. Younger daughter, who is 6 years old, is concerned about what has happened to her brothers. And the parents were seeking multiple medical opinion to see if the child could be cured from various hospitals. Because when the child are suffering from malignancy or different type of cancer, various thoughts of management may come from different corner. So sometimes parents may be confused, or they want to try everything just to save their child's life. This is also happening in this case also. There one better thing is that good family support from both parental and maternal side. That is economically more or less they are sound. Next slide, please. And spiritual concerns. Regarding these things, parents questioning why this is happening in their family. They have also had faith, but not are struggling to understand how God could allow this to happen. Mother felt what was the use of money if it could not help them save their child. It's a very stressful condition for the family actually. Next slide. In communication, multiple meeting while in hospital as well as daily video phone follow-ups once discharged home. And consistent initial message that we hope to that their son get well, and worry it might not be the case of cure. Family were taking multiple medical options. We encourage them to spend time with child and explain how to help with pain and breathlessness. Home visits were done for symptom management as well as empower parents to take care of the child. Next slide. So this is the same question which I actually gave in my second slide. In that case, what do you think? What are the sources of this child or family sufferings? What do you think? We can go for open discussion actually.
So thank you, Dr. Jarnat, for your interesting case. There are many challenging points you have raised. I would first like to invite if there are any questions from anyone to clarify this case, not for answering the key question just here, just clarify any part of the case itself. Does anyone need to clarify any points?
So in this case, Janet, it sounds like the patient will not be cured from what I know about the osteosarcoma. Would you say that's accurate?
Yeah, actually this is not now in a curative situation. So whatever here the mainstay of management is palliative care along with medical management also. So how meticulously or how empathetically and how holistically we can give them, actually that would be our concern. Actually, one question has come. Commonly in osteosarcoma, if the child does not present early, then cancer spread to the lung, which means that it is very difficult to cure. Yes, this is actually correct. In our country, where there is we are not in developed country, we are in developing or underdeveloped country, where there is other than educational factor, we have several type of myths culturally, which is actually engaged. Sometimes it may positively influence us, but most of the time it influences negatively. So actually, when osteosarcoma, child suffering from osteosarcoma, sometimes they may say bad ear, or sometimes bad thing, bad image, may got this swelling of the limb or something like that. And for this, they may go to the not in a doctor, other than what we are saying, quack or other philanthropic other area for the management. In that time, it become it will go for upstaging, and it is spread. And generally after 3 to 4 months, it actually goes in advanced stage. So in that case, if the patient has come with advanced stage, actually chance for curative stage actually reducing. And in that time, palliative support we need, actually strongly need in this case.
So this child is not in a curative situation, and now we can start to address the key questions. Let's start with this question: that what are the sources of this child and family sufferings, and how can palliative care help this child and the family? So what are some ideas about how to address this? You can share your thoughts and ideas. There are no wrong answers, actually. The point of this is to have a discussion and share your ideas. You can unmute and talk, or you can write in chat also.
Maybe I'll just comment. I think, when I look at this situation, this is what we come up with families all the time. Their child is sick and there is such uncertainty. And I think that's the suffering, is that the child doesn't know what's happening to their body. The parents don't know how they'll live with a sick child or with a child who's going to die. So I think that suffering is just enormous. And in some ways, we can feel kind of helpless. We want to give medicine, we want to cure, we want to help, but the team can feel very hopeless. And I think one of the ways that I've managed to continue in this work is to sit with that uncertainty with them and then focus on what can we do today? How can we make your child's pain and breathlessness better today? How can we make the brothers and sisters smile and play with their sibling when he's not in pain? How can we listen to the mom express her sadness about her child's illness without trying to fix it, because we might not be able to fix it. So that would be what I would say. Really, palliative care needs to think about the future for the child and the family, but to focus on today.
Thank you, Kamara, for your nice thoughts. And thank you, Dr. Bhatt, that you explained that we should go with the 4 components of palliative care to deal with this child. Any thoughts from anyone for this case?
Maybe I want to call on Nazia if she's available, in terms of maybe what are some of the emotional needs that you see they might have, because I know this is your area of expertise, is you're working in as a psychotherapist. So maybe just share what you see as some of the big challenges for the patient and family.
Ma'am, would you please repeat the question?
Yes. So I was just saying, if you can share what you see, because your background is in psychotherapy.
Yes.
What are some of the things that you're thinking about when you hear about the patient and the family like this? Like, how would you think about, in your role, how could you help them, or what are some of the big problems that you see that they have from a psychosocial point of view?
Okay, thank you, ma'am. The thing is, I haven't started any palliative care work yet. But what we see when we go through this kind of emotional scenarios, at the time we work on their ventilation. We listen to them very carefully, and along with all the criteria of active listening, and we try to give the first aid, psychological first aid, if he or she or the family members wherever they require. Basically, we focus on ventilating them through active listening, being with them, and their feeling, sorting out their feeling, and then replacing it. This is the way. These are the primary support we give this way, primary support.
Thank you. That's very helpful. I think, many of our participants are doctors and nurses, so they're not so even familiar with maybe active listening techniques. So I'm glad you mentioned, just allowing the patient to ventilate, being with them, expressing their feeling, having them express their feelings. Dr. Bhatt, do you want to say what you wrote in the chat and share that with everybody? Might be nice.
Yeah, hi, ma'am. So usually we see a lot of families basically the caregivers, like the parents most of the time, or even for that matter, most of our caregivers are actually grandparents here. What happens is these kids are generally between 13 to 16 years of age, and they have casts, they are not mobile, or they cannot bear weight, and they need a lot of admissions because most of the chemotherapies are infusional chemotherapies for days together, and post that they have fever and febrile neutropenias. So we kind of require support from the first cycle of chemotherapy for most of the patients, even if they are curative intent, in the sense that because we see that compared to the peers, like I'm just talking about this case, compared to say other tumors like blood cancers or some other tumors, there is a lot of burnout which we feel which occurs in the caregivers with this particular type of disease, like for example bone tumors, or even for that matter brain tumors as well. So any comments or thoughts on that?
Kamara, do you want to make a comment on that, or do you want me to? Oh, you already did. Okay, say what you wrote.
Yes, I agree that that treatment for osteosarcoma and other cancers is just so difficult for the patient and so difficult for the family. And what I see when palliative care can support the oncology team, this is another set of eyes and another set of hands that can really look at the whole child and the whole family. And often one way I explain our team is we're an added layer of support. We hope your child will be cured. We hope your child will have a long life. We hope the treatment works. We're going to be here to make sure that the days getting treatment and the time between treatment is going to go better. And we work with your oncology team to help that. So I agree to start really early and build that relationship is helpful.
Thank you, Kamala. And thank you, Dr. Shobika. You comments that the parents of the child in their son is also have a developmental delay, so they are in module. Do you want to comment on that?
Shobika, do you want to expand on what you said? It's really a nice point.
Actually, sorry, Megan. Actually, I want to add with this another thing. The child has a one sister also. She is very much concerned with their brother, regarding her brother. So and elder brother having developmental delay. So how we can support this child actually in this situation, in this scenario? I think this is also a big concern.
Yeah, I think this is a very big concern. How do we support brothers and sisters of children who are ill? Because they suffer a lot too. When we interview them, they talk about feeling like they're forgotten, feeling completely like they have no information about what is happening, and that they want information. Because remember, one thing that happens if children don't have information, they invent information, they imagine something, and the thing they imagine is worse than reality. Like they can make up something completely in their mind. So an example would be for the 6-year-old, because if nobody tells her what's happening and what's going on and why, she may imagine something like, I was angry at my brother last week and I hit him, and now look, he's very, very sick and he might, and everyone's crying and he might die. And she might think she caused it. And then the 6-year-old is so worried and so upset, but they don't tell anybody. They just keep all that worry inside. So it's very important for us to take time to talk to the parents And I think this is something especially that, the nurses could do at the bedside. You could say to the mother, have you talked to the 6-year-old? And you can tell the mother, it's important to tell your 6-year-old a little bit what's going on. Tell her that he is sick and he's taking medicine. Tell her that the doctors are trying to help him. Tell her that it's not caused by anything she did. Because those are the main worries that children have. And then the other main worry of young children is, who is going to take care of me, right? They're very egocentric. So they're worried about themselves, which is important. They have to survive. So the 6-year-old might be worried. The mother's not with her. Maybe the mother's in the hospital with the other child. So she's going to be worried, who's going to take care of me? Where's my mother? I need my mother. And so reassuring her, when will the mother come home? Who's going to take care of her when the mother's not there? Just giving reassurance about who's going to take care of her will be also very supportive.
Thank you, Megan.
Thank you, Megan.
I want to mention there's a really good website. I'm going to share it in the chat. It's called Kids Grief. And it is a website for parents about how to talk to your child about something sad, basically, something very major, about serious illness, about death and dying. Okay. And so I often ask families to look at this, and I encourage you, all of our participants, to look through the website and just see, what does it say? I'll show you on the screen, actually, because it's very nicely laid out about how do you talk to children, teens and kids, about serious illness and death and dying. So you can see here, and it gives, actually, there's a part for educators, like for teachers, because these children come to school. And then there's a part for parents, which is also good for us to look at, how to talk about death and dying, how to understand and sort of find moments to talk to them. So I would really encourage you to look through all of this. And it's all little videos of parents talking about what they did, and just people sharing about their stories. And we'll share that in the WhatsApp group as well. But that's specifically mainly geared to the brothers and sisters.
Thank you, Megan, for sharing. So we are at the some final thoughts now, and we are going to close our today's session. If you have no any other questions or comments, then I'm going to announce the session. Do any participant have any questions or anything? Thank you all for your inputs and discussions. Thank you all for joining today. Thank you especially Dr. Megan Doherty and Dr. Jannat, our speakers and presenters, for your nice clarification. Here are some announcements for our next session. Next week on 22 October at 7:30 p.m. on the topic of supportive communication with parents, breaking bad news. So it is an important topic, so make sure, please make time to see the preload video of next presentation. We will share the video recording on by WhatsApp in the next few days. So thank you and goodbye, everyone. Take care.
Thank you, everyone. Nice to see you. And we'll have some new faculty next week. Dr. Spandana will join us from India. So we're really looking forward to that. So have a nice week, and see you in 1 week's time.
Thank you, Megan. Thank you all.
Thank you, everybody. See you.